extensive lecture, so I need you to focus, if you don't mind. Okay? Any question you're allowed, raise your hand and ask. You're welcome. So our main objective is to understand clinical and logical presentation of common pleural and pulmonary diseases, to know what's the first workup and how to deal with these cases, and to learn the common radiological and findings, and how to and when to order, and what's your differential diagnosis when you deal with them. So basically, lung divided in two lobes, right and left. Right has three, right upper, middle, and lower lung lobes. This is supplied by trachea. Trachea at the center, divided into right and left main bronchus. Right main bronchus has an upper lobe, intermedius, upper, middle, and lower, where the left side has a left main bronchus, upper lobe, and lower lobe. When we comment about chest X-ray, the way I do it is assess the center of the heart, center of the chest X-ray, and go peripheral. So first thing I assess is the mediastinum. How the mediastinum look? Is the patient first centered or not centered or rotated? So patient centered. Is it a good images or bad images? And then how's the trachea look? So is the trachea centralized? Right main bronchus, left main bronchus, do they do well? Assess the right heart border, so mainly it's the right atrium, right lung base, inferior heart border, which is right ventricle, left heart border, which is left ventricle, and then small left atrial appendage, small pulmonary artery, and the big one is the aortic knob. And then assess bilateral around the trachea, called paratracheal stripe, and then assess the lung. So assess the upper lobe in both sides, middle lobe or middle zone in both sides, and lower zone in both sides. Also assess the CB angle, and then cardiac angles in both sides. And then once you're done with all, check the bones, so the ribs. So the linear is the posterior, the curvy one is the anterior. So this is the posterior one, and then anterior, posterior, anterior, posterior, anterior, posterior, anterior, and so on. Once you're done with that, check the upper abdomen, check the stomach, check for any free air, check the bones. So the bone starts with spine, spine's process, any fracture, clavicle, scapula. Once done, check the soft tissues around the side as well as in the neck. So this is more or less the way I do it. Pulmonary arteries, similar distribution, similar to bronchus. So upper lobe, middle lobe, and lower lobe on the right side, upper lobe and lower lobe on the left side, and then it has segmental branches. So this is an example of normal chest X-ray. One is we need to see is, do we have a good exposure? Yes, we do. We can see the lungs black and mediastinum is whitish. That's good exposure. It's not purely black, but it's black enough to see if there is anything abnormal inside. 2, do I see CB angle? Yes, I do. Okay? Barely see it here, but barely enough to see it. Do I see lung apices? Yes, I do. However, the first strip I didn't see it, so it's kind of incomplete assessment. I barely see the scapula, so it's kind of incomplete assessment. So it's better to have a full evaluation of scapula, part of the scapula when you see it. Although this is chest X-ray, but I would make a little bit touch higher up. 3, is the patient centralized? The way we know if the patient center is the clavicle. The clavicle has to touch or the kiss at the level of the spinous process, and you can see the spinous process in a straight point. So this is a straight centralized patient. Sometimes it's expected to see a little bit deviation of the trachea, and that's not normal. Okay? A little bit of deviation is acceptable. So in terms of assessment, the first thing to assess is the trachea. So trachea is centralized, divided into right main, left main bronchus, no filling defect inside it. 2, check the cardiac mediastinum. So this is the right atrial border. This is also border for SVC higher up and IVC below diaphragm, or at the level of the diaphragm. So any abnormality in this area, right atrium, SVC, IVC, this area will be affected. Then you have a right ventricle. So the right ventricle is the bottom border of the heart. Left ventricle is the left side border of the heart. Next to it, sometime we see the left atrial appendage, not the left atrium, left atrial appendage. Then the pulmonary trunk, sometimes slightly prominent, and then the main one is the aortic knob. Once we do that, we make sure there is no abnormality. You have to see many of normal, so we can assess what's the abnormal look like. So it's good to keep your eye looking at all chest X-ray you encounter and read the report so you can know how the normal look like and then what the abnormal should look like. Once you assess all area, you check the stride of the paratracheal, right paratracheal, left paratracheal. It's not normal to have more than like 3 or 4 millimeters in the paratracheal stride, especially the right side. Okay, when it's widened or enlarged, it's indicated there is abnormal mass in the mediastinum. Once we complete the mediastinum, we move to the lung. The lung divides into 3 zones: upper zone, middle zone, lower zone. It's called zone on chest X-ray, not the lobe, zone. Okay? Because you have a middle zone on both sides. You have an upper zone in both sides. So check the upper zone in each side, check for any opacity, check for consolidation, for mass, for pneumothorax, etc. So compare each side to each one. Usually they are comparable. Area that you can miss easily is the retrocardiac, the paratracheal region, and the retrocardiac tear. Because sometimes small abnormality can overlap with that, and because it has different density, we will not catch it. Next, you assess for CV angle. Make sure there is no effusion, no fluid there, no blood. Then assess the upper abdomen, check the stomach, check for any air under the diaphragm, check the soft tissue around the skin, then check for the bone, clavicle, scapula, both sides, and count the rib. So this is the posterior part of the rib, posterior part of the rib, posterior part of the rib, anterior part of the rib, anterior rib, anterior rib, anterior rib. Is that clear? Then, this is another example of different view, or frontal view. Can show you that's aortic knob, pulmonary artery, atrial appendage is not present, left ventricle, left atrium, right atrium, and then you see here the paratracheal stride around the trachea, and this is the lung zone, and that's the small lines. This is a normal vascularity of the lung. Okay? The lung has 2 types of vascularity, arterial and venous, and that's normal to see these white lines. Crowding is not usual, it's not normal sometimes, so you have to be careful when you see it. In terms of the lung, why do we use the word zones? Zones because there is overlap between the lung. So the upper lobe can take almost half the lung, while lower lobe can take more than almost 2/3 of the lung on ABV. And middle lobe overlap with lower lobe. So the way we differentiate between these is to use the lateral. So the lateral of the upper lobe never overlap with the lower lobe, never overlap with the middle lobe. So if it's going to be like a triangular, middle lobe is a triangle anterior at the level of the heart, this area. Lower lobe is triangular posterior, and upper lobe is semicircle at the top of the lung. So if you need to differentiate between upper, middle, and lower, you have to have a lateral or CT scan. Sometimes it is very difficult to find on a frontal chest X-ray. Okay. Number 2, these divisions based on fissure. Okay. And the fissure, the minor fissure, only seen on, can be seen on front and lateral, while the major fissure, we only see it on lateral. So we don't see this line on frontal view. Yes, sometimes we can see fluid there, but we don't see anything, rarely to see anything on the major fissure, on AP or EAP. Lateral of chest X-ray, you have the right ventricle anterior, left ventricle posterior, and then you have the aortic arch. Ascending aorta, transverse aorta, and descending aorta. And at the center is the pulmonary arteries, and at the center is the hilum of the mediastinum. Normally, the lung become loosened when we go down. Anyone knows why? Why the lung is black at its basis compared to the top here?
More air, gravity.
Why here it's black? There's gravity here. صح عليك بس.
cold air, hot air.
No. When you do lateral, there's a scapula. Okay? So the scapula has an opacity that make the tissue is difficult. While at the bottom of the lung, there's no scapula. Okay? So the reason for that is presence of bones overlapping with the chest X-ray. Okay. Any abnormality in this? Yes, no? What is this called?
Trachea.
And what's this time here?
Stripe.
Huh?
Stripe.
So,
سترايب
سترايب لا سترايب هذا سترايب معناتها خط رايت باراتريكيال ليفت باراتريكيال هذا زي الدم شو هنا؟ هذا وش يعني؟ ايوه ترى سمعت هالكلام سبانس بروسس This one?
كلينيكال.
ها؟ Nice. Right, that can Which rib is this one?
Fourth.
Fifth. Fifth. This fifth. First. Second. Third. Fourth. Fifth. Posterior anterior. Anterior oblique. Okay. What does this call?
CB.
Huh? CB angle. Fantastic. What's this border? What's this one?
Aortic knob.
Huh? Aortic knob. Yes, which one? This one?
Stomach.
Stomach bubble. Okay. So, CT chest basically is multiple X-ray. We use it with a special computer that can create these images. There are 3 planes: axial, so you slice patient top to bottom, coronal, anterior to posterior, and sagittal, medial to lateral, lateral to medial. So we are at the top of, so this is axial, this is coronal. So we are at the top of the chest or thoracic. Here we can see the brachiocephalic artery or innominate artery, and then give a branch to the right subclavian, right common carotid, then left common carotid and left subclavian. The black things is air, So this is the trachea, this is the right lung and left lung. Next to the trachea, always you have the esophagus. This is the muscle of the anterior chest wall. This is the scapula and the muscle around the scapula. Vertebra, left scapula, and that's the breast tissue. That's the part of the breast tissue. And that's start to see a glandular part of the breast tissue. So this is the aortic arch at the level of the transverse aorta or aortic arch. This one is the SVC, trachea and esophagus, right lung and left lung. That's a pulmonary artery, descending aorta, esophagus, left main, right main bronchus. This is called a soft tissue window. So in soft tissue window, we cannot see the line because everything is black. We have to change to something called lung window, and we'll see it later. Move down, you can see the right atrium, right ventricle, left atrium, left ventricle, and LVT, left ventricle outflow. And that's the aortic root. At the level of the heart, we only have a descending aorta. You will never see a pulmonary artery at the level of the heart, just higher up. And you will never see a pulmonary artery at the level of that transverse or aortic arch. It's below. So you have to know this basically. And then when we start to see the liver, it's almost we don't see any atrium, it's just the ventricles. So right ventricle and left ventricle. And this is a coronal view where we see the SVC. What are the SVC train?
Right.
Huh?
Right atrium.
Right atrium. That's a right atrium. Left atrium, left ventricle. We don't see the left ventricle on this view. Part of the stomach, part of the spleen, and part of the part of the stomach, part of the spleen. So this is the lung window. So that's the window where you can see the lung very well, but you didn't see the other tissues well. Main bronchus divided to right and left, and then upper and lower lobes. And that's the fissure. Again, you are higher up, above the bifurcation, above pulmonary, so you are almost at the level of the upper lobe. When things divide for bronchi, you start to see the middle and lower, and when you go down, it's a lower lobe. So, what's the indication, or what's the investigation that we use? CT, or chest imaging. The common is common, chest X-ray is the most common thing to use. Next is CT scan, ultrasound a few times, rarely MRI, nuclear imaging for
Metastasis.
hour. Good, go on. VQ scan. Anyone knows what's a VQ scan?
PE.
PE. Familiar. And then angiography. When do you use angiography?
Embolism.
Pulmonary embolism.
Embolism.
For just feed them.
Location.
CT. The treatment. Okay. So when we decide to treat patient with PE, that otherwise CT would be more than enough. Okay. Chest X-ray is the most performed exam. Almost the first exam to be done. It can assist the lung, pleura, part of the upper abdomen, and bones. The basic projection is posterior anterior, so the patient will stay facing the detector. That's called the source, the master. detector, اللاقط. So you will have beams coming this way, and when you touch the detector, the size will be similar. If you stay at this area, everything will be magnified. Okay? So the far you stay from the detector, things will become magnified. And we don't like things to get magnified. Okay? It's not always, because things can exaggerate, and we're trying to avoid that. And patient hand will be at the waist, so the scapula will stay a little bit away and minimize the effect of the scapula. When you do lateral, patient will have above their head or his head, so the scapula will still present but less. If the patient is standing like this way and do lateral, the hand artifact will affect the lateral view, so it will be suboptimal variation. So it's always, you have to put the hand above the head, or at least touching the shoulder. So chest lateral, as we mentioned, help us to do localization, upper, middle, and lower horizontal. Why do we need that? We need to know what is the center of the disease. Is the upper lobe or is the lower lobe? Portable chest X-ray can be done for especially sick patient. It has a very limited rule because we do AP, so there will be magnification here. The distance between the detector and the patient is variable. It's not like when you stand. So there will be some haziness because it's not the optimal disc. And the patient cannot take a deep breath when they lie down. Okay? If you're standing, you can take a deep breath. But if you lie down, you cannot take a good deep breath. Lateral decubitus, helpful to identify small fusion or trapped air. Usually like it in pediatric. You can wrap them and just do the exam, especially for pneumothorax or pleural fusion. Although pleural fusion can be seen with ultrasound, so maybe it can be a little bit. So this is a case where we see there is increased lucency on the left pneumothorax compared to the right side. If you lie on your right lung, the right lung that you're lying at will get smaller, okay, like this one. Okay. But if the patient has a foreign body like this one, you can see there is a foreign body there. There is increased air trapping inside the lung because the air cannot leave the lung and stays inside, and that's the reason of hyperlucencies there. So the indications for chest X-ray is true lung infection, anaphylaxis, pleural fusion, pneumothorax, fluid overload, and sometimes to follow up things. Small nodules, maybe not, but usually not. Interstitial lung disease sometime if it's advanced, otherwise sometimes can be missed. This is an important thing. What the thing can be normal in chest X-ray? One, you have asthma, emphysema, very small nodule less than 5 millimeter, PE, infection like BCV or DVTB, diffuse lung disease like cystic lung disease, small fusion. So those findings can get normal, and having normal chest X-ray does not mean you send your patient home. You're not dealing with machine, you're dealing with patient. So if you think your patient is sick, you need to do additional work after that. Why do we do a chest X-ray for patient with PE?
Which infarction?
I define it, but why do we do it? What's the reason for chest X-ray?
Communication. Communication.
Communication?
Complication.
Complication. Method?
Crossing.
Huh?
Crossing.
البروسس. متى يصير البروسس؟ أنت عندك
So
ضوابط
complete-
قاعد عندك علاج. كنت عندك خطة علاج مستشفى ضوابط. مستشفى علاج جوال علاج. قال هذا الخط عنده بي دي وشو بشوفها؟ نقدر نشوف الشيست اكس راي؟ لا لازم نسوي سي تي. بس كيف نسوي شيست اكس راي؟
Without pneumothorax.
وراث هيموثوركس or وش الفايندنج حق بي دي؟ كيف تعرف انه بي دي؟ يلا هذا عادي انا بجربكم.
Multisys.
ها؟ هيموكسيسس
Sinus tachycardia. Or other findings. ECG. Other findings for ECG.
لسه بترايج ما اسوي نفس الشيء.
كلاس بالكوريك.
هذا كلاس من فوق يعني انت ديزني. عنده ديزنيا، عنده تكيبنيا، تكيكارديا. هل لازم عنده كلهن؟ لا. طيب ممكن يجيك واحد نورمال صح؟ ايش الديفرنشال diagnosis in someone with dyspnea؟
Heart failure.
heart failure. بعد pneumonia. بعد pneumothorax. بعد PD. بعد الوضع. طيب. فالchest X-ray can help you to know or targeting your differential diagnosis. لو واحد جاك عنده pneumothorax وانت قاعد تسوي سي تي chest ياخذ له ساعة ساعة. كم ما المريض ما له ما يقولوش ساعة. ف yes, sometimes we know it's not helpful in the main diagnosis, but it can help you to exclude other life-threatening etiologies. Or sometimes you avoid doing even further of that. جاك واحد عنده سوى chest X-ray يقول heart failure خلاص. There's no reason to do additional إلا لو طلع ECG finding and D-dimer etc. في other findings to suggest you have to do PE study and that's another discussion. طيب CT carry a lot of radiation compared to X-ray. It's even reached to more than 150 X-ray. Nowadays maybe it's like around 100. Anyhow, it's a lot of radiation. So, is radiation dangerous? Yes. Can we avoid it? Yes. When to avoid it? As much as you can. However, the amount of radiation is still low on energy. Very low. We have a lot of background radiation. Okay? When you travel, all the time you have radiation. When you walk in the sun, you have radiation. Okay? Sometimes you cannot avoid it, but that's normal. There is a number of amount of radiation you are allowed to have it per day, and that is acceptable and very good. Once the radiation is higher, then it's called a radiation zone, and people have limited access to it. So we always advocate for as low as radiation as possible. However, if you need a radiation, we must do it because your patient will need to be treated in the proper way. Okay? You cannot delay patient care because of risk of radiation. That's the message I have to make. Indication for CT chest. One, you suspect vascular pathology, aortic dissection, aortic injury, PE. You suspect a mass, and you need to further evaluate the mass because you need to know what type of mass, how we can stage it, if there's metastasis, etc. So that's it. If the patient has trauma, and trauma means there's fractures, sometimes pneumothorax, aortic injury, so yes. If you suspect pleural infection in pyelina, and sometimes we use it when we do procedure like drainage or biopsy. HRCT is similar to the CT. We just have a quite heavy thickness compared to the usual thickness, and usually do it without contrast. It helps us to see two things: one, interstitial lung disease, as well as bronchiectasis. Pulmonary angiography is we're using contrast to assess pulmonary artery. How can we do? Anyone have attended any PE study before? How do we inject the patient? نو زيرو مرة أحد يحاول يفكر كل مرة شافها وناسي. طيب we inject through the veins, okay? Although it's coronary artery, but inject through the vein. How can it reach to the coronary artery? يلا شغلوا مخكم. تبغى الصيف؟ شلون؟
السيركيليشن
حلو. شلون نشرح يعني؟
توقف عند من الرياض.
ما عندنا اشرح لي. أنا حطيت بالبريك البين. وين تروح؟
سبيل الكتاب.
حلو وبعدين حطيت كل هذول. ايوه. تدري وش يقول لك عنه؟
وين؟
بين سكينة.
سبكيليتي.
قبله. أكزيلاري. حلو. أكزيلاري بين سبكيتين بين هم.
سبيل الكتاب.
قبله. بريكوس الفعالية. سوبر من الكتابة بعدين.
رايت ليتري.
رايت اتريم. رايت اتريم.
ضمن.
pulmonary artery بعدين. هذا احنا الحين وش سوينا بي اي. لو اسوي اورطة سي تي انجيو. كمل السيركوليشن pulmonary vein. خلاص pulmonary artery ترجع pulmonary vein صح؟
ليفت ليتري.
left atrium. left ventricle aorta. كم تاخذ عشان تصل اورطة؟ minimum 30 second. اوكي؟ يعني من 15 to 30. ف if you want to do a PE study عادة نقول التايم حقه 10 second 10 15 second. لو اسوي aortic study 15 to 30 second. وبسوي شيء اسمه venous phase ابغى اشوف ابغى اشوف الفين ايش معناته ابغى يروح يكمل ياخذ دور كامل بالجسم وبعدين يرجع للفين. هذا تاخذ 70 second. This is for normal population. هذا اسمه timing or phases of imaging. بعدين نبغى نشوف من اليوريتر ياخذ له 3 دقائق إلى 5 دقائق عشان ديلي عشان يطلع security freeze. أبغى أشوف بلادر كم minutes. Okay. All can be done with single injection. So what's indication for CT angio? To assist pulmonary vein, pulmonary artery, to assist the aorta, so if you split an injury, that can be done. Ultrasound, it helps us to detect very small pleural effusion that's not seen well on chest X-ray. Ultrasound can take as minimal as possible, like 5 to 8. So it's the most sensitive exam to assess fluid is ultrasound. And can detect or help to differentiate between simple and complicated or complex fluid. We can use ultrasound for guidance in thermal biopsy and drainage also. MRI chest almost never happen for mediastinum, however, we do it for posterior mediastinum when it's related to nerve sheath tumor, or for superior mediastinum when there is pancreas tumor and it's invading the brachial plexus. VQ study is a nuclear study that we use 2 types of isotope. One isotope we inhale it, we take an image, and then other one we inject into the patient and assist the pulmonary artery. Normally, when you inhale, you will have this image. When you have blood supply injection, you will have this image. If these images are symmetrical, we call it match. When things match, they match to each other, there is no PE. When things mismatch, which means the inhalation is normal, but blood is abnormal, which is called perfusion, then that suggests a film defect or mismatch and suggests of pulmonary embolism. Like in this one, you can see there is a mismatch in this area. There's a film defect here. That's normal here. So that's the inhalation, and this is the perfusion. We'll take a break, like 5 minutes.